Well, hello, everybody. Good afternoon, and welcome to this last session, but this interesting session about the collateral damage of COVID-19 on child health. So I'm very happy to be the chair of this session. And as you can all imagine, we couldn't organize this edition of the Pediatric Days without talking about COVID. Actually, in most of the other sessions that we have seen yesterday and today, COVID has appeared at some point of the session. So it's clear that we needed to give it a dedicated space. So this is the place for it. And during this session, we are going to see together and to understand together that actually during this pandemic, the biggest or the most dangerous threat for child health is not the COVID-19 disease itself, but all the indirect impact that is having in the healthcare activities related with pediatrics. So we will explore the challenges that we are facing in our activities. We will see also the potential long-term effects that this pandemic can bring to child health, but also we want to bring also and to show the opportunities that this crisis is bringing and can still bring to our medical and humanitarian activities. I didn't want to lose this opportunity first to thank all the people that has been involved somehow in the development of this session, especially all the participants that we are having today. So thanks a lot for your time, your enthusiasm, and your commitment. And secondly, but most important, I want to thank all the field teams, because since the beginning of this COVID-19 pandemic, you have been giving the best you can in order to maintain and to adapt our healthcare activities in the community, in the ambulatory services, and in the patient services. So all this, you have been doing it in difficult situations. So I think it's fair enough to tell you a big thank you. And yeah, that was one thing I wanted to share with you. So now, without more delay, I'm going to start. We're going to start with the content of the session. And we are going to do first an overview of the indirect impact of COVID-19. And for this, we have with us Kim West, who has a background on public health, and she's been working with MSF since 2011 with different roles in communication, in advocacy, and in operational research. And currently, she's the medical advisor, the medical advocacy advisor for MSF. So Kim, welcome, and the floor is yours.
Thank you very much, Anna, and good afternoon, everyone, wherever in the world you're tuning in from. And I'd just like to thank the organisers and presenters for what has been a really fascinating and inspiring event so far. So to kick off this session, I'm going to start by giving a quick overview of trends that we are seeing both in MSF projects and globally regarding how COVID has affected and continues to affect other aspects of child health, or the so-called collateral impacts. Now, we only have 10 minutes, but I wanted to touch upon three main areas. So how COVID is affecting health service delivery, how COVID is affecting health-seeking behaviour, and how COVID is affecting wider social determinants of health. So next slide, please. So I think if we flash back to this time last year, everyone will be familiar with the severe resource constraints that were really hampering almost every organization's ability to deliver quality healthcare. And so by resource constraints, I would say these relate to three main areas. So one, financing, secondly, supply, and thirdly, human resources. So on the financing side, we know that COVID has been an expensive cost for every country, and we know that there are not infinite pots of money. COVID response has been an unexpected cost for governments and all health actors. So last year, in many contexts, we saw a diversion of resources, particularly of emergency response capacity, away from regular health programming towards the COVID response. And I think mid to long term, we can expect to see much less money allocated to healthcare. Large scale unemployment means that tax revenue has fallen and there will be less money for governments to spend on health. This also includes donor countries who will have less to allocate as foreign aid. UK government, who is one of the largest donors to global health and humanitarian work, has recently announced what will be enormous cuts. So this means that less money to support ministries of health and non-governmental organizations. So in terms of health service delivery, we could expect to see some health facilities might close altogether, or services or certain packages of care might be scaled back or stopped. On the commodity side, I think we all remember the fight for personal protective equipment last year as supply struggled to meet the global demand. I think although there are still many challenges with supply and distribution mechanisms because of the pandemic, another consideration is the risk that the manufacture of certain essential commodities needed for child health are diverted to products related to COVID care. So some of you may be aware that one of the biggest manufacturers of malaria rapid diagnostic tests diverted its production capacity to more lucrative COVID tests. And these market forces mean that there is the potential for similar things to happen with other commodities. On the human resource side, MSF and many other organizations have had to make difficult decisions as we struggle to balance the duty of care we have for our staff with the duty to care for our patients. So as MSF, COVID meant we removed high-risk staff from frontline care, and this is alongside staff being unable to work due to quarantine, illness, caring responsibilities, etc. So of course, this has resulted in a more limited health workforce available to deliver care. So how to juggle these constraints with ensuring the effective health service delivery is something that all health actors have been grappling with. I know as MSF OCPA, we have been cognizant of the collateral impacts since the start of the pandemic, and yet operational decisions, thus with factors outside of our control, meant that last year, we had to close some programs sooner than expected and put on hold our plans for scale up and expansion of non-COVID activities. So these constraints have been affecting every layer of health service delivery, both preventive and curative services. I wanted to specifically note the impact on preventive measures that are delivered in kind of mass settings, because so many campaigns were postponed or cancelled last year as they were considered mass gathering events and would be difficult to manage in terms of social distancing or because of the lack of resources to do them effectively. We know that this could have severe impacts on child health when we think about mass vaccinations, supplementary feeding programs, or net distributions, for example. I know one of our presenters will discuss vaccination in more detail, and I look forward to hearing more from her on this issue. So what does this mean in real terms? To put it simply, a more limited access to preventive measures could lead to more vaccine preventable diseases, malnutrition, malaria, and so on. And if the child is sick, the health facility near them may not be open or have the resources available to deliver quality care. And as a side note, I would stress that in this resource-constrained environment, something we really need to be paying extra attention to is quality of care. So of course, these challenges impact on morbidity and mortality, but I think something we also need to consider is the impact on communities' perception of the health system. Next slide, please. If people have not been able to access quality care when they need it, it might prevent them from doing so in future. Some of our field teams have also reported that there is decreasing public confidence in health systems because health facilities and health staff are perceived as sources of COVID virus transmission. This is against a backdrop of confusing public health messaging related to COVID, where stay-at-home or quarantine messaging might have been misinterpreted, particularly as COVID symptoms are similar to that of other diseases, such as respiratory infections. So this may mean that children with similar symptoms might have parents or caregivers might have thought that they had to deal with their child's illness at home. Messaging related to social distancing might also increase fear of gathering in public and may reduce uptake of public health interventions delivered in mass settings in the future. And of course, we have to be conscious about the proliferation of misinformation and disinformation about healthcare. This existed pre-pandemic, but COVID is causing it to explode. If we use the example of vaccination, we have all read the safety concerns about COVID vaccines. It's not unlikely that this could lead to wider vaccine hesitancy for other commonly used vaccines. So all this means that we can expect to see changing patterns of health-seeking behaviour. which could include avoidance of care or choosing non-evidence-based strategies for care. And this could all result in low uptake of preventive measures or children arriving late and not at all for health facilities. It's clear that good community engagement is at the heart of us trying to understand evolving population perceptions and how to mitigate against any impacts which will reach far beyond COVID itself. So next slide, please. Lastly, I just wanted to discuss the impact on the wider social determinants of health or drivers of ill health and how COVID is affecting this. So we have already touched on the economic crisis that is upon us due to COVID, but I want us to think about the impact of this on individual households. At the start of the outbreak, much attention was paid to the economic impact of containment measures on people, particularly those employed in the formal sector. However, because some countries are now relaxing restrictions does not mean that employment will go back to what it was pre-pandemic. And of course, earning potential for many households is still affected by quarantine, isolation, sickness, increasing care responsibilities, etc. The impact of this loss of income is that households will have to reduce consumption, which in practice turns into missed meals for children, less access to clean drinking water, and less money available to access healthcare when needed, either for transportation or for out-of-pocket payments. There is a body of evidence that shows child health can suffer due to negative shocks in parental income, causing issues such as chronic undernutrition and even influencing adult life expectancy. Although the mandate of MSF is not related to poverty alleviation, I challenge the people in this meeting to reflect on how we can stop children being readmitted to the ITFC or prevent other diseases strongly associated with poverty. We also know that poverty can lead to increases in violence, and a report from Save the Children published last year estimated that violence in the home has more than doubled due to the pandemic environment. So alongside children potentially being exposed to higher levels of violence, containment measures and school closures mean they could be trapped at home with an abuser. Some children won't be able to return to school, and I think the gender dimension is really important to consider here because UN agencies and others are predicting girls to be particularly vulnerable here, with increased risks of child marriage or working or transactional sex, which of course comes with it unintended pregnancies or early pregnancies and all of the health consequences that come with that. School closures are another important dimension that is going to impact on child health, and I think this will be discussed more by one of our speakers later. Of course, it means less access to things such as school nutrition programs and obviously the social, emotional, developmental aspects that come with access to a rich education. So these dynamics paint a worrying picture for child mental health. So I apologize if this was a bit of a whistle-stop overview, but I hope I have given some food for thought about how all of these issues can impact on child physical health and mental health. I think we need to be cognizant of the fact that some of these impacts are not going to be explicitly visible. Just because we are seeing not seeing an increase in patients at facilities does not mean that health needs are not increasing. So I think this means we really need to engage our curiosity. So at the patient level, looking at the child's needs just beyond the medical. These could look at protection concerns, for example, and also looking outside of the health facility at changing and evolving community health system and social dynamics that could be impacting on population's health. Thank you for your time, and now I'll hand back over to Anna.
Thank you very much, Kim, for this nice overview. And I think we are going to have the possibility of going more in detail in some of these main areas that, of course, in 10 minutes, it's not easy to tackle. So, but thanks a lot. I think it's a very nice overview. And now I'm going to say that for the preparation of this session, we did a survey that we shared to the field because we wanted to have some inputs from the field about how COVID-19 was affecting the running of the pediatric healthcare activities. So this survey was done at the end of 2020. It had 10 questions and we sent it to all MSF missions, but it was answered by all the projects that had at some point pediatric activities. The survey covered the period between March and mid-December of 2020. And we had a total of 56 projects filling the survey. So big thanks to all of them for the time that they for doing this. And during this session, I'm going to show you only some of the results of the survey, but for those projects who wants to see all the survey results, it's already available in the Paediatric Working Group SharePoint in the Paediatric Days section. So you can check it there. Next slide, please. So one of the questions that we did in the survey was about how the ambulatory pediatric services were running during the period between March and mid-December. No, in order, we wanted to understand what was the trend in the fields. So as you can see in the slide, almost 50% of the project who answered this question, they said that there was a reduction in the pediatric ambulatory services, that it included EPI, ambulatory therapeutic feeding centers, or OPD consultations, whatever type of ambulatory service. So some of the reasons that we received from the field for this reduction during this period were related with the restriction measures that the population and also the healthcare teams had, especially at the beginning of the pandemic. The perception in some communities and the fear of attending to the healthcare facilities to see it as a high risk of infection of COVID. Also, some projects told us that there was some population displacement due to insecurity or farm tasks that were probably related with this, that reflected this reduction in the ambulatory services. So now to continue with some information from the field, we are moving now to the field experience, okay? Because in this session we want to give voice to the field in order to understand better how they have been facing and adapting their activities during this COVID-19 pandemic. And we are going to have the testimony of 2 projects and an oral abstract presentation. We are going to keep the questions for the 3 presentations at the end, but I encourage you that during each presentation you can already put your questions in the question box that you can see in your screen, because like this we will go through some of them after we have done the 3 presentations.